right, so this will be a discussion on the cardiac physiology, and we'll kind of tie in some of the things that we talked about in lecture, as well as some of the things we talked about in the electrocardiogram lab. And the main things that we're going to be covering in this section of the heart is the things that influence the heart, both in terms of the rate of contraction, so your beats per minute or your heart rate, and then the strength of the contraction and the different environmental or the different internal and external factors that will influence the function of the heart. So the first thing here is just reminding you what cardiac output is. So cardiac output is the actual volume of blood that's pumped by each ventricle in 1 minute. Now, the way that they can actually measure this is they use an echocardiogram, not to be confused with an electrocardiogram, but the echocardiogram, ECHO. It's kind of like an ultrasound for the heart, and they can visualize the amount of volume that's being pumped out. The other way that they can do this is they can actually send in a catheter and collect, but obviously that's highly invasive, so they just used advanced imaging in the form of an echocardiogram in order to demonstrate the amount of volume being pumped by the blood, by the heart, the volume of blood being pumped by the heart, specifically by each ventricle per minute. You get an estimate. So by definition, cardiac output equals the heart rate times the stroke volume. Now, heart rate is the number of beats per minute, so that's typically abbreviated BPM. So in lab, I had you measure your BPM. I had you measure your resting heart rate, your heart rate when standing, and then your post-exercise heart rate, and then average those out and then kind of see where you fall. So you can see here the average is about 70 beats per minute. Everyone's heart rate, resting heart rate, is a little bit different. It can be varied by level of fitness, level of activity, age, and things like that can all play a role and a factor in the BPM. So this is that average of 70 beats per minute is typically for an adult that weighs around 70 kilograms or 150 pounds. And so obviously you're going to see variations depending on gender, height, weight, and then, like I mentioned before, level of activity. I track my heart rate using a Fitbit device, and my resting heart rate tends to be in the mid to high 50s. And so, and like I said, everyone's just a little bit different. When there's times of stress or I got things going on, I'll definitely see that resting heart rate increase. And that's one of the reasons I track it, because first of all, I just think it's interesting and I like to look at the graphs. But it's just something that we can track. Stroke volume is, again, the volume of blood pumped out by one ventricle with each beat. Again, that amount is about 70. The range is anywhere from 50 milliliters to 100 milliliters. But again, the average is about 70 milliliters. Again, the average is based off of a 70 kilogram or 150 pound person. Typical cardiac output is about 5 liters per minute. So if you think about in 60 seconds time, your body is pumping that amount of blood, 5 liters, which is like 2.5, bottles of pop through your body, which is just kind of cool. Just kind of continues to circulate that throughout the body at a pretty impressive rate. Now, there are factors, obviously, that will increase that and then, of course, decrease that. Like when you're at rest or you're sleeping, your cardiac output is going to reduce a little bit because your level of activity is reduced. But when you increase activity, like you're exercising, you can expect to see that cardiac output actually increase significantly. So there's several factors that can affect heart rate, and there are also several factors that can affect the stroke volume. So for heart rate, we have autonomic innervation. So hopefully you remember what that refers to, but we're talking about the autonomic nervous system, the ANS. And that consists of two branches, the sympathetic and the parasympathetic. Okay. And so you may remember that the sympathetic nervous system is your fight or flight system. And if you remember that the sympathetic is your fight or flight system, you'll realize that if you're in a fight or if you're running for your life, your heart rate will what? It will increase, okay? But in the parasympathetic, that tends to be your rest and digest part of your autonomic nervous system. So what do you think your heart rate is doing when you're resting or digesting? Okay? It's going to be slowing down. So just kind of some things. Different hormones can affect heart rate, like the thyroid hormones have an influence on your heart rate. Glucagon, which is part of your blood sugar balancing hormones, has an effect on heart rate. Fitness levels. Are you very fit? Are you a couch potato? Are you kind of in between? Where are you at? And then, of course, age plays a role as well. For stroke volume, the size of someone's heart. If you remember from last week, I mentioned that if you take your fist and put it on your chest, your fist is about the size of your heart. And so everyone's heart is just a different size. You've seen people with big hands and you've seen people with small hands, and you can make an estimate of the size of the heart based off of that. There's also comorbidities that can influence the size of the heart, but that's not necessarily what we're talking about here. Fitness levels, again, will impact stroke volume. You might say, I know people who are highly fit, who have very low resting heart rates, but on the flip side of that, their stroke volume is actually much higher. So there's a way to kind of balance that out so that the cardiac output is still the same. Contractility, so things that influence the strength of contraction, so basically how much output is being generated. The duration of the contraction, so how long is the contraction occurring. The preload, which is represented by what's known as the end diastolic volume. So as we talked about in class, we talked about diastole is when the heart relaxes. And remember, when it relaxes, that means it's filling with blood. And every time we're talking about systole and diastole, remember, we're thinking about in terms of the ventricles. A lot of these terms are in regards to the ventricles. Don't get caught up trying to think about what the atria are doing. It's important, but in terms of the cardiac output, we really just care about what the ventricles are doing. So end diastolic volume is the volume that is being generated or filled in the ventricles at the end of diastole. And so the more there is, then it means that there's more fluid to pump through the body, and that increases what is known as preload. Afterload is the resistance that volume needs to be pushed against, meaning what are the blood vessels doing? Does this person have any other comorbidities that might be affecting resistance, meaning are they doing something that would cause their blood vessels to become more constricted? Or what if they have clogged arteries, which is known as atherosclerosis? Or what if they have arteriosclerosis, which is hardening of the arteries? What if they have a valve that's malfunctioning? A malfunctioning valve is going to increase resistance, particularly a malfunctioning semilunar valve. So all those things affect stroke volume. So you can see here that stroke volume is a measurement of the end diastolic volume, so the high number associated with how much volume is going to be found within the ventricles when it's maximally filled, and then end systolic volume is how much is left. So let's say I fill it up to 70 and then I get rid of all of it, then we would say that my stroke volume would be minimal. Now obviously we wouldn't want this to be 0, right? But if you say 70 minus 0, then it would be 70. Okay, does that make sense? Also, what if it was 120 minus 50? Are we still within the range of ejecting or getting a stroke volume of 70 milliliters? Well, yes. So let me just write that out just because I said something really fast and I just want to make sure you're seeing this. So let's say I have 120 milliliters. So the number I'm writing here, just know that it's milliliters. I'm not going to write ml. So 120 milliliters is the end diastolic volume. So the volume at the end of diastole when the ventricles are at their fullest. And at the end of systole, we've pushed out all but 50 milliliters. Okay? So 120 minus 50 gives me 70. Okay. So 70 would give me my systolic, or my stroke volume. Okay. I just wanted you to know where I was getting that from. Okay. So let's talk about the external factors that innervate the heart. And what this image is showing you, first of all, hopefully you remember looking at, here's your brain, here's your diencephalon, here's your thalamus, your intothalamic adhesion, here's where your pituitary is, your hypothalamus, your pineal gland, here's your cerebellum, your cerebrum, and then we get into what is commonly referred to as the brainstem. The brainstem consists of the midbrain, the pons, which is kind of like the belly, and then the medulla oblongata, which is down in, kind of continues on into the spinal cord and then makes its way on down. Now, you'll see that there's two areas here that are actually located on the medulla oblongata, and these are your cardiac regulatory centers, which there's different terms that I've seen associated with these. So they say there's the cardio-excellatory center and then the cardio-inhibitory center. So cardio-excellatory, what does that sound like? It sounds like it's going to make the heart work harder. Okay, so think increased heart rate. The cardio-inhibitory center is the things that are going to slow it down. Okay, and then you have two branches. You have the parasympathetic, which is the cardio-inhibitory center. Remember, the parasympathetic is actually going to slow it down. The sympathetic is going to speed it up, so that would be your cardio-excellatory center. But both have innervation, or start their innervation at the level of the medulla oblongata. So the vagus nerve, if you remember, the vagus nerve is cranial nerve 10, and the vagus nerve actually has both motor and sensory function. So it's actually hanging out and it's detecting what the heart is doing at different areas of the heart. So in the heart itself, and then there's in some of the major blood vessels, and it's receiving that information and bringing that information back up to the medulla, and it's telling, and then the medulla determines, okay, do we need to increase heart rate or do we need to decrease heart rate? Do we need to increase the rate and strength of contraction, or do we need to decrease the rate and strength of contraction? So if you want to think of the vagus nerve as just kind of the information that's being sent back. It's bringing the data back to the medulla and telling basically the brainstem what's going on. Now, if you recall from when you learned about the nervous system in A&P1, you know that this structure is considered primordial, and that all vertebrates have this basic structure of a brainstem, including the medulla, the pons, and the midbrain. And then we start to further develop into these structures, the cerebellum and the cerebrum, as we become more advanced or more evolved, however you want to interpret that. Okay. Now, the vagus nerve can have information going to and from, and it's detecting information, like I said, from the heart and from some of the major blood vessels. But the sympathetic nerves that are coming off here are actually coming out of the sympathetic chain ganglia, which, believe it or not, doesn't start until below the level of T2. So your second thoracic spinal innervation is where the cardiac sympathetic nerves are actually located. But anyways, what I'm getting at here is they just send information to the heart in order to tell the heart to fire, to increase heart rate, increase strength of contraction, and things like that. The vagus, though, is the one that calms it down, slows it down, and it also is the one that's detecting information. There's actually another nerve that's located here. It's the cranial nerve 9. Cranial nerve 9, if you don't remember, is also known as the glossopharyngeal. So glosso refers to tongue, pharyngeal refers to the throat, and you may remember that it is responsible for detecting bitterness in the back, in the posterior 2/3 of the tongue, and then also into the throat. It's also why sometimes when someone's having a heart attack, they may say that they have like a bitter taste in their mouth, and that can be because it also has nerve fibers that are going to detect what's happening at the level of the heart. So the vagus nerve, cranial nerve 10, and the glossopharyngeal nerve, cranial nerve 9, both are monitoring heart function. So you can see here that the cardio-excellatory center, part of the cardiac center, is going to trigger a sympathetic response. And what that's going to do, it's going to affect both the sinoatrial and the atrioventricular node, so the SA node and the AV node. It's going to basically allow them to increase the rate of contraction of the heart muscle, okay? And it's also going to influence the coronary arteries, okay? One of the things that we want to have happen is if we're increasing the rate of contraction and the strength of contraction, do you think we want more or less blood getting to the heart? And the answer to that, and what I mean is to the coronary circulation of the heart. And the answer is we want more. We want to make sure that we're getting lots and lots of blood supply to the heart muscle. So we're going to actually increase the amount of blood getting to the coronary arteries so that way we can maximize ATP production in the heart muscles to make more and more, to increase the rate and strength of contraction. On the flip side, the cardio-inhibitory center is going to be driven by the parasympathetic, which is actually going to inhibit the sinoatrial and AV nodes, and then it does so through the vagus nerve. Okay, the vagus nerve. I know it says vagus nerves. That's because the vagus nerve has several branches associated with it. This is something I'll tell you now, and you'll hear later on. I always tell students at this stage, at some point in time, you're going to be asked a question about which cranial nerve does blah. And usually the answer to that question is the vagus nerve. The vagus nerve, vagus means it's the wanderer, and it's because you're going to find the vagus nerve innervating lots of things. It's associated with the heart, as we're learning now. Later on, we'll talk about its role in the respiratory system. And then even later on, we'll talk about its role in the digestive system. So the vagus nerve literally is going to be found everywhere, and it's involved with most everything. And it's the major nerve associated with parasympathetic regulation. So it's your major parasympathetic nerve regulator for visceral activity. So the rest and digest is basically predominantly controlled by your vagus nerve. All right, so here are some extreme variations that can occur as a result of heart rate, and this is what we looked at in lab. Tachycardia, remember that's the resting adult heart rate above 100 beats per minute. Now we have to add adult heart rate because children, like toddlers, adolescents, their heart rate is going to be much higher and be considered normal than an adult heart rate. And that has a lot to do with the level of metabolic activity. What are kids doing, right? They're growing constantly. What are they always asking for? Food, right? And that's because they're constantly in a state of growth, and so they're going to also have an increase in heart rate. But when we're talking about an adult might experience tachycardia, which is defined as a heart rate above 100 beats per minute, and there can be some underlying factors that can be contributing to that. Stress, anxiety, certain types of drugs and medications, both illegal drugs and legal drugs, heart disease, or maybe they're fighting off an infection and they have a fever. Tachycardia can also occur when there's significant loss of blood, such as think of like a major trauma, or someone's bleeding out of their arteries after like a car accident or a significant trauma, or even think about like a woman giving birth and she loses too much blood during the birthing process. You might see tachycardia associated with that, and of course damage to the myocardium. So when I see damage to the myocardium, the first thing I think of is heart attack. Okay. Now, let me ask you something. This is actually kind of interesting that we mention heart attack here with the myocardium. if the myocardium is damaged, and in a heart attack, when that cardiac muscle is destroyed, it becomes scar tissue. It's no longer able to contract. It doesn't do its normal function anymore. And then now I'm increasing heart rate. Does that make it more or less difficult for the heart to function? And the answer to that is it's going to make it significantly more difficult, because you're asking the heart to do more, and it's actually missing muscle now. And so it's going to have a hard time keeping up. And so it's one of those things that we call or consider a positive feedback cycle that occurs with loss of blood and with myocardial damage. It creates the recipe for shock, and shock can unfortunately lead to death if it's not appropriately treated. Bradycardia is the opposite of tachycardia. It's slow, a slow heart rate, the resting adult heart rate of less than 60 beats per minute. So this is normal in sleep, but it can also occur with low body temperature. But it can also be normal in endurance-trained athletes. A lot of times when we're concerned about bradycardia, it's someone who doesn't fit into those categories. They're awake, their body temperature is normal, and they're not an endurance-trained athlete, and their resting heart rate is very low. So I already told you my resting heart rate is low. But when I do that calculation on my Fitbit, that's throughout the entire day, including when I'm asleep at night. Okay. And I've looked at my heart rate. My heart rate can get down into the 50s and even into the 40s when I'm asleep. But when I'm awake, my heart rate definitely is elevated. So like right now, sitting here doing this lecture with you guys, my heart rate's is in the 80s actually. And so throughout the day, there's fluctuations. So I'm not bradycardic. But also the other thing is there are signs and symptoms associated with bradycardia that would, when present, is also needed for that. So like feeling like sleepy, having headaches. There might be further evaluation in which cardiac arrhythmia might be present. And so those are all things that are also important indicators other than just a low heart rate. Also, you can argue like, oh, well, you could have a resting adult heart rate above 100 BPM if you were exercising. But then if you're exercising right, that's not rest. Okay, so that's the difference here. And then you can see the ECG strips for the tachycardia and then for bradycardia. And notice that the main difference is the QRS complex. You can see the spacing versus how quick this is happening here. And then the rest of the wave actually looks relatively normal. All right. So let's get into more specifics on regulation of stroke volume. So stroke volume, again, remember that's end diastolic volume when the ventricles are filled with blood, and then minus the end systolic volume after the ventricles have contracted systole, and then now there's less blood in the chamber. So the end diastolic volume is affected by the length of the ventricular diastole as well as venous pressure. So what venous pressure is how much blood is being returned to the heart. Okay, so you have you're constantly in circulation, but how much of that is being returned to the heart? Is it 100%? Is it 90%? Is it 110%? All those factors can be regulated by basically how much fluid is being returned to the heart. So what would be a way to regulate venous pressure? Well, drinking water and going to the bathroom. Okay, those are two ways. So later on when we talk about kidneys and the urinary system, we'll actually talk about how the kidneys are the major regulator for blood pressure. Long-term blood pressure regulation is actually a function of the kidneys more so than that of the heart. If you want to think of it, the heart primarily, its primary job is just to circulate blood through the body. And then there's other factors outside the heart that are actually going to contribute more to blood pressure regulation, which we'll get into when we get to the blood vessels next chapter. Okay. Then the length of ventricular diastole. How long is the heart in a state of diastole? And then it's not so much about the timing at this point to be concerned about, but let's go back to thinking about bradycardia and tachycardia. In tachycardia, what do you think the length of ventricular diastole is? It's going to be pretty short, right? It's going to be very short, because as soon as it's going to fill, and then it's immediately going to contract, fill, contract, fill, contract, fill, contract. You're going to have a very short length of ventricular diastole. What about bradycardia? In bradycardia, you're going to see a little bit more of a pronounced and have a little bit more time because there's less beats per minute. So you're going to see ventricular diastole, and then you're going to see ventricular systole. Then you're going to see ventricular diastole, then you're going to see ventricular systole. It's going to be a much slower process, so you're going to see an increase in length, okay? So you're going to actually see more volume that actually needs to be pumped by the heart, and so that has to be accounted for when affecting stroke volume. So stroke volume is going to be affected by preload, which is the amount of venous return or venous pressure, and then afterload. Afterload is the end systolic volume, the arterial blood pressure, the force of the ventricular contraction, as well as the function of the semilunar valves, so the aortic and pulmonary semilunar valves. So afterload is going to affect the stroke volume as well. And then the level of contractility. So how strong is the contraction, or how weak is the contraction? Let's go back to, let's look at tachycardia. Tachycardia, even though you're getting a high, fast rate of contraction, you're actually getting a weaker response of contraction. And so that, and remember, one of the things associated with tachycardia was loss of blood volume, as well as damage to the myocardium. So you're actually going to see kind of like they're contracting, but you're not getting a full contraction out of it. There's just one way to kind of think about that. Bradycardia is similar. You're going to actually get also a weak contraction, but it's slower. Unless that bradycardia is in someone who's like an endurance athlete, then you're actually going to get an increase in strength of contraction with each slow heartbeat. And so the contraction plus the resistance and then the heart rate all are going to play a role in how the stroke volume is going to be generated. Okay. Now remember, cardiac output is represented by heart rate times stroke volume. So we're really focusing on the stroke volume. I'm trying to tie in the fact that heart rate also has an influence on some of these factors as well, but more so overall on cardiac output. All right, so again, what is preload? I already mentioned this. This is the amount of blood that needs to be pumped by the heart that's brought back to the heart. So think about, it's called the venous return. It's the amount of blood returning to the heart, getting back to the right side of the atrium, the amount of blood that's coming in from the vena cava, the coronary sinus, and how much needs to, again, be circulated, how much needs to get pushed to the lungs, how much needs to get pushed throughout the rest of the body. And it's basically what creates the tension needed to generate, or that occurs as a result of diastole, okay? So so it says here the amount of tension in ventricular myocardium immediately before it begins to contract. So basically how much blood is there, and we measure that with the end diastolic volume. End diastolic volume is a representation of preload, okay? So the more the cardiomyocytes are stretched, so they get stretched out, the harder they contract. And then there is a limit to which muscle cells can get stretched, but thankfully we have that fibrous pericardium that actually prevents the cardiomyocytes from being overly stretched. So there's actually things that prevent that. Also, you have lungs in the way, you have a diaphragm, you have a sternum, you have a spine. All those things help to prevent overstretching, meaning overfilling of the heart. And so it's almost like pulling a rubber band back. You pull it, you put it between your fingers and you pull it apart. What happens if I let it go, right? It's gonna snap back. It's exactly what's happening here as a result of the preload. It's basically like, winding up for the pitch, or if you ever make, rubber band, shooters or rubber band guns where you wrap it around your hand, you're creating tension, and then when you release it, fires, okay? So again, the venous return is how much blood is returning to the heart. Then that return stretches the ventricles and gets the cardiomyocytes ready to fire. Slow heartbeat and exercise will actually increase your venous return. Okay, so exercise actually helps to push the blood that's sitting in the lower extremities up into and return it back to the heart. Increased venous return distends or stretches the ventricles, and then again increases the contraction force. So, all right, contractility. Contractility is the strength of the muscle at the particular length that it is. So it's actually independent of muscle stretch and end diastolic volume. It's going to be affected by what are known as positive inotropic agents. So positive inotropic agents, inotropic just means the things that cause it to contract more strongly. So positive inotropic agents increases the strength of contraction. Negative inotropic agents decreases the strength of contraction. So some examples of things and agents that increase positive inotropic or increase the rate of contraction. There's thyroxine, which is part of your thyroid hormones. Glucagon, which is the hormone that's responsible for actually bringing blood sugar back into the blood. So glucagon is kind of the opposite of insulin, okay? Or it is the opposite of insulin. Epinephrine. So epinephrine is the hormone or the neurotransmitter. You can look at those kind of interchangeably, but epinephrine is part of your sympathetic fight or flight neurotransmitter that's released, and so it's going to cause an increase in the strength of contraction. Digitalis, and then another way to think about epinephrine, and epinephrine is also known as adrenaline. So if you've ever had that adrenaline rush, you've technically had an epinephrine rush. And what are you doing when you have an adrenaline rush? You might be running, you might be exercising, something along those lines. Or you might be watching a really good movie and, whoa, I'm getting an adrenaline rush. Okay. Digitalis is a medication that acts as that increases the strength of contraction. And then having excess or high, or I won't say excess, but having high extracellular calcium will also increase the strength of contraction. And that's actually one of the things that some of these other agents actually help to facilitate, is increasing extracellular calcium as well as making the cell wall more permeable so that more calcium can get in, so we can get a stronger contraction. What about on the factors that decrease the strength of contraction? Well, if someone has acidosis, so acidosis, and we'll talk more about this in the next chapter, or we might talk more about this actually in the respiratory chapter, but acidosis is when the pH of the blood, if you remember in chapter 18, we talked about blood pH being in a range of 7.35 to 7.45. And so that means it's below, or it's closer to, or even below that 7.35 number. And when that pH gets too low, we're going to see a decrease in the rate of contraction of the heart. Also, when there is excess extracellular potassium. Now, potassium, if you recall from when you learned about the action potential, and we talked about that in regards to the heart as well, potassium is what regulates the resting membrane potential. And so if you have excess potassium, you actually are not going, your resting membrane potential becomes higher. And typically we think of when it's higher, that usually means that the cell is going to fire more rapidly, which is true, but your contraction is going to be much weaker. Okay. And then calcium channel blockers. So let's say we're trying to lower someone's blood pressure. We might actually give them a calcium channel blocker in order to decrease the strength of contraction of the heart in order to lower blood pressure. Okay. So these are the factors that are going to increase the strength of contraction, and then the factors that are going to decrease the strength of contraction. Afterload. The afterload, remember, that's the resistance that the ventricles have to move against. Okay, so there's a couple things to think about. So remember, the heart is constantly pumping, right? Every beat is a ventricular contraction, and so that means there's always blood in your blood vessels. And so one of the areas that you have to work against is you need to be able to generate enough blood pressure to get past the blood pressure that's created in the aorta. When the aorta has a low blood pressure of around 80 millimeters of mercury. So, and that's what contributes to when we measure blood pressure around 120 over 80, we need to be able to overcome that 80, otherwise we're going to have some problems. The pulmonary trunk immediately distal to the semilunar valves also contributes because the pulmonary trunk also has blood already sitting in it, and we need to be able to overcome that. And that blood pressure is usually between 20 and 40 millimeters of mercury. So the opening of the valves are going to be limited by the pressure against those valves outside of the heart, okay? And so when the valves do open, then we have basically an opposing force caused by the blood pressure in the aorta and the pulmonary trunk going against the ventricular push, and the valves help to regulate stroke volume in that term. And that's good. We need a little bit of resistance because that's also how we build up a strong, healthy heart. Hypertension, right? So high blood pressure will also increase the resistance, the afterload, and it prevents proper ventricular ejection. And then anything else that might impede the arterial circulation can also increase afterload. So let's think about, so here it says lung diseases. You know, if somebody has what's called pulmonary hypertension, emphysema, COPD, all those things are going to increase the afterload associated primarily with the pulmonary circuit. And then I also mentioned earlier atherosclerosis, okay? You know, clogged arteries is also going to increase the afterload. All right, so this is just a good overview of the factors that are affecting stroke volume. So things that will cause an increase in stroke volume would be if the preload has a fast filling time and if there's an increased venous return. So we're going to see an increase in the EDV, which is the end diastolic volume. And we're also going to see an increase in the stroke volume. With contractility, we're going to see it we're going to see it affecting stroke volume when the sympathetics are being released. Sympathetics are going to contribute epinephrine and norepinephrine, and that's going to affect and increase the strength of contraction. There's going to be an increase in intracellular calcium ions. When there's high intracellular calcium ions, we get an increased strength of contraction, and epinephrine and norepinephrine actually help to facilitate their utilization. High blood calcium levels, so outside of the cell, so high extracellular calcium ions also plays a role in that. Your thyroid hormones and glucagon will also increase the strength of contraction, okay? Now, you can see here that it decreases the end systolic volume. That's actually what we want to have happen. The higher the diastolic volume, the end diastolic volume, and the lower the systolic volume usually means that you're getting an increase in stroke volume. So they're opposite each other. So notice here, increased end diastolic volume, decreased end systolic volume, we're going to see an increase in stroke volume. So they are opposites that work together to increase stroke volume. So don't get hung up on, just remember that the end of systole, we want that number to be really low, okay? Or we want it to be much lower than the end diastolic volume. And then the afterload. Now, some of the things that you're actually going to see is you're going to see an increase in vascular resistance will actually negatively affect stroke volume. So again, what are some things that increase vascular resistance? We talked about certain types of lung diseases, and then cardiovascular diseases will also play, as well as damage to the semilunar valves. Okay, so if someone has a valve, a semilunar valve that's not working properly, that's going to affect the afterload. It's going to actually increase the afterload meaning that we're not going to be able to push out as much of the blood that we would like to get out of the ventricle, and that's going to actually cause a decrease in stroke volume. Okay, and then you can review the things that lower, lower the stroke volume, and then you can see when you have a decreased vascular resistance, and then notice how these things are basically opposite each other. Okay, so I'll leave that for you to review. All right, so let's talk about the other chemical regulators for heart rate and contractility. You have hormones such as epinephrine. So epinephrine, as I mentioned before, is associated with the sympathetic response. And what happens is your sympathetic chain ganglia will actually send signals right down to your adrenal medulla and cause the adrenal medulla to release epinephrine and norepinephrine, also known as adrenaline and noradrenaline. Okay, and what these do is they actually increase the heart rate and they increase the strength of contraction. The thyroxine also increases heart rate. It also enhances the effects of norepinephrine and epinephrine. So thyroxine, remember, that's thyroid hormone. Okay, that's thyroid hormone. Thyroid hormone is important for metabolic regulation, so it regulates metabolism. The other thing I wanted to mention real quick is the opposite of epinephrine is not norepinephrine. If we're looking at neurotransmitters that seem to do opposite functions, if you want to just classify sympathetic versus parasympathetic, remember the parasympathetic neurotransmitter is actually acetylcholine, which is typically abbreviated capital A, capital C, lowercase h. But acetylcholine, ACH, acetylcholine, is the opposite of epinephrine when we're talking about in terms of what's happening with heart rate and strength of contraction. Norepinephrine, that nor just means, for those of you who took or has already taken chemistry, you're either going to have flashbacks or you're going to get excited because you liked chemistry. But norepinephrine just means that there's a methyl group that's in a different position on the norepinephrine than it is on the epinephrine. So epinephrine and norepinephrine have the same chemical configuration, meaning the same carbons, hydrogens, oxygens, and whatever else makes up epinephrine. But they have a methyl group located in a different area, which makes it norepinephrine. And they also have different functions, and we'll talk about those a little bit more when we get to the blood vessels. I want to save some fun stuff for the blood vessels. Okay. Chronotypes. Chronotypes are things that are going to affect the heart rate. So positive chronotropic agents will actually raise the heart rate, and the negative chronotropic agents will actually lower the heart rate. So what are the ones that we've already talked about? Well, positive chronotropic agents that raise the heart rate include the sympathetic nervous system. Okay, adrenaline, noradrenaline, epinephrine, norepinephrine. Negative chronotropic agents will actually lower the heart rate. So negative chronotropic agents include the parasympathetics. Acetylcholine would be a good example of lowering the heart rate. Inotropes, we already talked about these. Inotropes are the things that affect contractility, or the strength of contraction. So you have positive inotropic agents will increase contractility, while the negative inotropic agents will reduce contractility. So what's an example of a positive inotropic agent that increases contractility? Again, sympathetic nervous system, epinephrine, norepinephrine, adrenaline, noradrenaline. Negative inotropic agents that reduce contractility, again, parasympathetic, the acetylcholine. And then, of course, you can go back to the previous slide. I'll just show you real quick, where you can also look at the things that are going to affect contractility. Parasympathetic, acetylcholine. You can see hypoxia and hyperkalemia is also going to be listed there. Hypoxia is low blood oxygen levels, and hyperkalemia is excess potassium, and we talked about that in the previous slides. All right, so this graphic just goes through and breaks up the different factors. Now notice there's a lot more things that seem to be affecting stroke volume than they are things that are affecting the heart rate. So the heart rate is going to be influenced by a couple of things. So the atrial reflex. Now, if I didn't mention this before, the atrial reflex is in the atria. The atria actually is also detecting pressure. Okay, it has it's got barometers or baroreceptors that are detecting pressure or changes in the expansion or the stretch within the atria. And so it's associated with venous return. It lets the heart know how much is there. A lot of times when the stretch receptors, like in the blood vessels, like in the kidney or in the carotid sinus or in the aortic arch, or the carotid body, when those aortic and carotid bodies is what I was trying to say, when those detect high amounts of stretch, they'll actually try and lower things down. They'll try and lowering blood pressure. And we'll talk more about those when we get to the next chapter on the blood vessels. But the atrial reflex, when it's actually when there's more stretch, that tells it that there's more venous return. And if there's more venous return, we actually want to increase the strength of contraction as a result of that, and also increase the heart rate. So the atrial reflex is going to be monitoring and helping to contribute to the autonomic innervation, meaning the glossopharyngeal nerve, cranial nerve 9, and the vagus nerve, cranial nerve 10, are detecting at the level of the atria, and then they're going to influence heart rate as a response of is the venous return high or is it low? Okay. And then hormones will also affect heart rate. So we talked about things like thyroxine is going to play a role in increasing heart rate. Glucagon will play a role more so in contractility, but it might play a role in heart rate as well, especially since if you have more blood sugar, you're probably going to see an increase in heart rate as well. And then the factors affecting stroke volume, again, very similar to the atrial reflex, is the amount of blood being returned to the atria, which contributes to the preload. We call that venous return. The amount of time it takes to fill. So remember, filling time is also going to be relative to the heart rate, the resting heart rate. Your autonomic innervation is also going to affect contractility. So remember, sympathetic and parasympathetic effects. Hormones are going to affect contractility. And then vasodilation and vasoconstriction. That's vasodilation literally means the blood vessels open up or dilate. And then vasoconstriction means the blood vessels close down or constrict. You're familiar with those terms, dilation and constriction, because you talked about the pupillary reflex when you did the special senses in AMP1. Afterload, contractility, and preload all contribute to the end systolic volume. So basically, how much am I pushing, what am I pushing against, and how much do I need to push are all going to contribute to the end systolic volume. Okay? And that's how we get to our cardiac output. So again, a couple just refreshers. So the autonomic regulation, let's talk about the sympathetic division. The sympathetic nervous system is going to be activated by emotional stressors as well as physical stressors. Okay, emotional stressors, think about, when there was a time when we were able to drive to CCAC in a 10 class live, and you're on your way and somebody cut you off, or you got stuck at a traffic light, or someone, just kind of just driving way too slow. What is the emotional stressor that does, because you're going to be late or you're not going to find a parking spot, and all those things basically will drive up your sympathetic response. Well, then what about physical stressors? That might be where there's actual, like, you just dodged a traffic accident, or, you're sitting on something that's like hot or cold, or, your kid left a toy car in your seat and you sit on it and hurt your butt. Those things are physical stressors. And the weird thing and the interesting thing is that whether it's emotional or physical, the response is the same. All we have are these tools in our bodies that are basically like the accelerator pedal and the brake pedal. And we either have things that cause us, to push the accelerator, your fight or flight, or to hit the brake, your parasympathetic, your rest and digest. And so when you know that, then you can kind of train your body or hack your body or hack your way to finding a little bit more balance with those systems, especially if they start to go a little bit haywire. Anyways, norepinephrine is actually the part of the sympathetic response that's going to affect the firing and the increasing in contractility. So norepinephrine actually is what causes the pacemaker of the heart, remember your SA node, to fire more rapidly. So we're going to increase the rate of firing, and then to increase contractility. Now, one of the things, if you've read the book, you'll see this in the book, they talk about if we didn't have parasympathetic innervation, your resting heart rate would probably be, or your heart muscle would probably be contracting at a rate of about 100 beats per minute. That's just what it does. And then your vagus nerve is constantly there saying, like, slow down, relax, it's okay. And it's kind of like lowering things down. And so what happens is when there's a sympathetic response, you take your foot off the brake and you put it on the gas pedal. Okay? Now, that doesn't mean you slam it on the gas pedal, but you take your foot off the brake, and so the heart rate actually would start to increase. And then if we want it to increase any more, the sympathetics kind of kick in and they increase it beyond 100 beats per minute. So anytime, or a way to think about this, and this is not 100% true in all instances, but a way to think about this is when your heart rate is above 100 beats per minute, it's because you're having a sympathetic response. So think about like when you're exercising, you're getting a sympathetic response because that's what we want, okay? And that would be a normal physical stressor that would actually be good for you is when you're doing some sort of exercise versus getting all worked up about someone cutting you off. All right. The way that norepinephrine works is it binds to what are known as the beta-1 adrenergic receptors, and the beta-1 adrenergic receptors are what are responsible for increasing the heart rate. Okay. As a response of binding to those adrenergic receptors. Think adrenergic kind of sounds like adrenaline, and that's because that's where they got their name from. When they bind, it actually causes an increase in the heart rate. We get increased contractility, and we also get faster relaxation. So we contract and we relax. We contract and we relax. We contract and we relax. And that helps to offset the lower end diastolic volume, because obviously if we have a faster relaxation, that means we're going to have a lower fill time, but we're getting a good strength of contraction. So even though we're seeing a decrease in the end diastolic volume, we're actually seeing an even though we're seeing a decrease in the end diastolic volume, we're seeing a more significant decrease in the end systolic volume, which helps to offset any lack or loss of the blood. So we are, by increasing the rate and increasing the strength of contraction, we're able to maintain the appropriate stroke volume. So again, think about exercise. And the other thing is, think about exercise in this way. If you didn't do those things, if your body didn't offset the lack of filling, then anytime you would exercise, you would pass out or fall down because you wouldn't be able to maintain the appropriate amount of cardiac output to get blood to like your heart or your legs or your arms, whatever you were exercising. So that's one way to kind of wrap your head around it. The parasympathetic division, this is going to oppose the sympathetic effects. So think about, it's the brakes, okay? Acetylcholine, you can see the word there, oftentimes abbreviated ACH, but acetylcholine is going to hyperpolarize the pacemaker cells, and when they hyperpolarize, what that means is you have an extreme in the polarity, you actually are going to cause a slowing of the heart rate. So you can see here it hyperpolarizes by opening the potassium channels. What happens when the potassium channels are open? You start to go back to the resting membrane potential, right? That's how we counteract. Remember when we talked about the action potential, sodium comes in, then we start to close the sodium channels, but then when calcium starts to come in, we're talking about the heart, and then after we close the sodium and the calcium channels, then potassium leaks out in order to bring the resting membrane potential back down. So if we are keeping the potassium channels open, we're actually going to cause heart rate to slow down. Okay. Really, the acetylcholine is not affecting contractility. It's just the fact that when the brakes are on, we're not on the gas as well. So the brakes are, when we're on the brakes, we're off the gas. Okay, when we're on the brakes, we're off the accelerator. And so by virtue of the fact that we're off the accelerator, it means we're getting less contractility. We're just getting normal contractility in that regards. The heart at rest exhibits vagal tone. And vagal tone is going to be the thing that ultimately influences your heart rate, your resting heart rate. So it says there that vagal tone is parasympathetic dominant influence, meaning that the parasympathetic division is actually what keeps your heart rate below that 100 that I told you earlier. And so it's always on. Basically, you're always on the brake with the heart unless it's time to activate the sympathetics. All right, what about electrolytes? Well, you have electrolytes such as potassium and calcium that are going to affect the heart, both in heart rate and contractility, and that was in the previous slide you saw. But hyperkalemia, you're going to see an excess in potassium diffusing into the cardiomyocytes. The myocardium then becomes less excitable, and when that happens, the heart rate slows down and it becomes irregular, okay, especially if it's beyond normal. Now, when I mentioned potassium before, you see how we're opening potassium channels. That's normal potassium amounts. But sometimes when the kidneys are malfunctioning, we actually get problems with the electrolyte balance, and it's the hyperkalemia and hypokalemia can have a negative impact on heart function, which is why we're talking about it here. So the myocardium is less excitable, the heart rate slows and becomes irregular. So that hyperkalemia might increase the likelihood of developing bradycardia and also arrhythmia. Hypokalemia means that there is too little potassium. The cells become hyperpolarized and they actually require more stimulation in order to fire. So that would be another thing where you're actually going to see a decrease in heart rate as a result of having too low potassium. So notice that too high and too low have an effect on the heart rate. I would say that hypokalemia has a more significant effect on both the strength of contraction and the heart rate, whereas the hyperkalemia is going to slow down the heart rate, but it's also going to create irregular heart rate and irregular strength of contraction. So it kind of makes it more, for lack of a better term, more cattywampus, just not functioning expectedly. So, and then if you're wondering, well, how do they measure these things? Well, they'll do a blood draw and they'll look for electrolytes and they'll look to see is it too high or too low. They'll also, evaluate that at the level of the kidney, the liver, and so when they do like a panel, they're going to be evaluating all these different factors. Calcium. When there's too much calcium, it actually also decreases the heart rate and contraction strength. Now, one of the reasons for that is because calcium actually, when there's too much, it actually starts to compete with sodium, and it also competes with hydrogen ions. And one of the things it does is it actually will affect the strength and rate of contraction of the heart. Hypocalcemia, where you're having too low calcium, will actually cause the opposite, which is it increases the heart rate and it increases the contraction strength. Now, a lot of times when we talk about hyper and hypocalcemia, we're talking about extracellular, meaning outside of the cells. A lot of times the strength of what's happening and the strength of contraction and the rate of contraction, all that's going to be relative to the intracellular calcium that's going to be found within like the T tubules of the skeletal muscle or the cardiac muscle. So having too much calcium on the outside actually competes with the sodium and actually causes a decrease in the heart rate and also contraction strength, whereas having too low of a calcium actually will increase the heart rate and contraction strength. Again, remember, these are too high and too low outside of the norms when we talk about that, because earlier on we talked about how calcium, we want to increase the amount of calcium that's going in, but we don't necessarily want to have more calcium than can go in, if that makes any sense. All right. So the final slide here is actually from an old McGraw-Hill textbook I used to teach from. And one of the things I always liked about it was it talked about the role of homeostasis when we talk about different things, like in this example, this is about blood pressure regulation. So we could say the same thing about heart rate, and that's why I'm showing you this, and we'll look at this again when we get to next chapter when we talk about blood pressure regulation. But notice that there's a healthy balance, a healthy range in which we maintain homeostasis. So if we get below the range, we need some factors that are actually going to cause us to bring us back into the healthy range. And if we get above the range, then we need to have some factors that will help us get back below or into the healthy range. Okay, so I know you don't have this image, but you can find this image if you do a Google search, you can find this image. And so I'll just tell you to get that there, because I don't know that I'm allowed to give you this image on a PowerPoint, but you can get that on your own. But you can see again, I'm going to show you how to follow this. I'm not going to read through all these. I just wanted to show you that this is one of the things that I always really liked about the physiology of anatomy and physiology, is just learning about the fact that we have this healthy range, okay? Meaning that we can go above and below like the average and be within a healthy normal range. So notice it falls that. And then I get to this point and I say, what if I have a severe drop in blood pressure? Well, that's bad. And so we have some things that will actually cause mechanisms to actually increase blood pressure, and you can see we could actually bring us back into that normal range. Here, if the blood pressure gets too high, what are some things that we can do? Well, there's a couple things here that will actually help to bring the blood pressure down when they become activated. And again, it's all about regulating homeostasis. And that's what we were just talking about, the things that are going to influence heart rate and strength of contraction. When we get into the next chapter, we're going to actually talk about those in terms of blood pressure regulation. So, if you have questions, make sure you let me know. I hope you got a lot out of this. And like I said, we're going to talk more about these things. This is kind of just an introduction. We're actually going to talk more about these later on as we get into the blood vessels and even into the kidneys. We're going to revisit a lot of these things, and you're going to see these repeated a little bit because they have influence in many different areas. So, all right.